So now we're going to have a panel discussion that will discuss working together to make 1 in 10 history. I now invite all the panelists, as well as Dr. Peggy Brown, who will be the facilitator of this panel, to come up.
So welcome to my panellists, and I'm not going to introduce you. I'm going to ask you to very quickly introduce yourself to the audience before we get underway with some questions. So I'll start with you, Brin.
So I'm Brin Grenyer. I'm from New South Wales. I direct a strategy called the Personality strategy called Project Air, and I'm also based at the University of Wollongong as a professor.
I think people know me.
Is this one on too? Yeah. I'm Louise McCutcheon. I helped set up the Helping Young People Early program in the northwest of Melbourne from Orygen, and we're now under the auspices of the Parkville Youth Mental Health and Wellbeing Service. Really long name, sorry everyone. So I've been working with young people with personality disorder and their families and supporters for the last 25 years or so.
I'm Sathya. I'm the director of Spectrum, which is a personality disorder and complex trauma specialist service in Victoria. Brin, if you don't mind, I think I need to mention that Brin is the current president of the International Society for Study of Personality Disorders, really the most authoritative clinical voice on this panel.
And I'm Cathy McLeod-Everitt. I'm the Service Development Manager at the Borderline Personality Disorder Collaborative, and that's the statewide specialist personality disorder service in South Australia.
Great. Thank you all, and we're very privileged to have you all with us for this panel discussion. I've got a series of questions, and I'm going to direct them to one of you to start, but then I open it up for any others to make any comments on each question as we go along. And it's great that you're sitting here closest to me, Brin, because I'm going to start with you. As the foremost international expert on the planet, I want to talk about access to appropriate treatment and care. As we know, BPD is a treatable condition, but not enough people actually receive appropriate treatment and support, despite the fact that we know that it's one of the best ways to actually prevent deaths from suicide for people with BPD. So in your view and your experience, which is extensive, how can services work together better to ensure that no one falls through the cracks?
Yeah, thanks, Peggy. Nice question to start with. Look, I mean, when we reflect upon the mental health system and the health system more broadly, I do like to think that in Australia we do have a fairly robust health system compared with a lot of countries. We do have, rigorous training pathways. We do have a lot of very skilled practitioners. And we do have a lot of both inpatient and community-based services of different types and persuasions. But are they serving what we really need in the field of borderline personality disorder? And I think that's the big challenge, is we have wonderful services, but in many ways they're not friendly and not set up well to work with people with personality disorders. So that really does require, I think, a whole bunch of different things. And I loved your analogy to, what's happened in cancer care and just the whole of community approach. It's really important that we think much more about how do we pull all the pieces together, and I think that's what today is about. And I congratulate the leaders of this conference for having the vision to see that is really what is needed. that we do need to have a plan, and we need to have a plan that looks at all different areas, not just health or mental health, but community, schools, family services, housing, and all sorts of other services. And how can we create bridges and a really well thought through approach that recognises that this is a group in our community that needs a specific type of approach. It's not rocket science what you need to do, but what the big challenge, though, I think, is that in many ways personality disorders, BPD, is kind of invisible, and it's not given the national priority. Now, I know that when you were on the Mental Health Commission, you did a spotlight on BPD. That was the exception to the rule. I think if you look at the national debate around mental health, personality disorders doesn't get mentioned. It wasn't in the national survey of mental health and well-being. And a lot of the time, I think it gets pulled apart and seen as something else. So it's suicide, or it's complex trauma, or it's treatment resistant, people with other kinds of diagnoses, and we don't really fully, say this is our priority. We need to do something specific with this, and for it to be an intentional, kind of from the top, as a political and leaders of mental health and the community statement that this is, we all agree that this is what we need to do better. So I think that's where we need to start.
Okay, others from the panel want to add anything? Louise?
I think one of the big challenges is that we have some crisis kind of responses, and we have some specialist services, and there's not a lot in between those two. And I guess what I would be advocating for is that we try and think about how we can have personality disorder responses being incorporated into routine clinical care, so that every clinician feels competent to respond in a helpful way when someone comes through the door with complex looking difficulties. Because actually they see those people all the time anyway, but they don't feel confident to respond. And we have somehow rarefied the treatment of personality disorders into something that sounds too hard for people, too difficult, too complex, to something else, something other than what I can do. And what we also know is that personality disorder is often about responding in a really simple way to people's needs. And so I think that one of the big things we need to do is have it be seen as routine clinical care, that clinicians know how to respond. They have already got the skills. Every clinician feels competent to respond in a helpful way when someone comes through the door with complex looking difficulties. Because actually they see those people all the time anyway, but they don't feel confident to respond. And we have somehow rarefied the treatment of personality disorders into something that sounds too hard for people, too difficult, too complex, to something else, something other than what I can do. And what we also know is that personality disorder is often about responding in a really simple way to people's needs. And so I think that one of the big things we need to do is have it be seen as routine clinical care, that clinicians know how to respond. They have already got the skills. Perhaps they need more supervision, or they might need more, building up on in certain areas of skills, but they actually have the basic skills to be able to respond helpfully, and at the moment they don't see themselves that way. So I think that's one of the biggest barriers. And thinking where the gaps are, unfortunately from state to state, systems look really different, and that's a huge problem, because then you get all sorts of gaps in your postcard lottery, which we've heard about a couple of times already today. So I think that would be my place to start, that it's about routine care, it's about really helping clinicians feel confident to be able to start doing some work, and perhaps there might be other services they can refer to or link to that are outside of mental health, because actually people with complex needs have complex needs and they may not be just mental health.
Sorry, Louise, just to clarify, so you're not
Yeah.
necessarily just meeting clinicians in mental health. Are you talking clinicians more broadly? GPs,
Well, I would say
EDs,
yes.
drug and alcohol?
Absolutely, yeah.
Thank you.
And from primary care all the way through the mental health system, but also the people that come into contact with people with personality disorder, so housing workers and drug and alcohol workers and all of those other people, child protection, etc., etc., etc.
Thank you. Sathya?
I want to very much agree with what Brin and Louise have been saying. I think we have sold treatment of borderline personality disorder or personality disorders as rocket science, as Brin was alluding to. Guess what? If it is rocket science, only a few people are going to be willing to do it. And also the fact that we have romanticized psychotherapy a bit too much. And what the current science of borderline personality disorder shows is that if you do good enough treatments and people do respond, we heard Megan beautifully explain what needs to be done by a family member. It's not very dissimilar to what we expect of clinicians. Again, we need to have all clinical workforce come on board. This might surprise you. I don't think really getting more funding is the answer. Yes, we would all appreciate more funding. Certainly the foundation needs more funding. But we do have, especially in the Australian healthcare system, we do have enough resources. I was just last night doing a back of the envelope sort of a calculation. Just Google some numbers. I think we have 120,000 clinicians, mental clinicians, if you include all GPs to put together. And if all of them could be trained to treat one or two people with borderline personality disorder, I think the crisis numbers can come down quite significantly. So, and we shouldn't be aiming at training them in highly sophisticated psychotherapy such as DBT or MBT. Nothing against DBT or MBT, but they have a place. But they need those generalist treatment skills, which can be easily done.
Cathy?
I was just going to agree with you, Louise, in terms of things are different in different states, and I think we've been very fortunate in South Australia where the government did fund a statewide specialist service, and we developed a statewide model of care that all of our services signed up to, and that was done in collaboration with lived experience as well. I think in terms of though how to implement it is one of the things that we've been learning over the past few years, but one of the thinking about how do we use like a hub and spoke model, because as a specialist service, if we did all the treatment, we wouldn't actually be able to service that many people. We're quite a small service. But by actually taking our role where we support the implementation of services in the services that already exist, then there can be a lot more service delivered. So we have a hub and spoke model that really is underpinning our implementation. So our specialist clinicians actually go out to each of the LHNs and they're linked with them to really understand the culture in those teams, to understand what their environments are, what their pressures are, their priorities, and then work with them through providing a structured implementation program to think about how do we support those services build their capacity so that we reduce that postcard lottery, because there's certainly pockets of excellence, but it's about the consistency of care that we really need to think about how we build that. And so by having our hub clinicians linked in with those services, we're really trying to build that momentum using the generalist models, Sathya, that you're talking about as well, thinking about how do we upskill generalist clinicians. There's a place for the specialist evidence-based therapies for people who are trained in those, but how do we support the generalist clinicians as well to really enhance the capacity of the whole workforce?
Great, thanks, Cathy. Can I just build on that then? Because I think that hub and spoke model is a great kind of concept. And Sathya, you do some of that. Brin Project Air does some of that. How do we take it from the initiatives that are there to actually get it out more widely? And sorry, this is an unscripted question.
In Victoria, we've been privileged to try that at a slightly larger scale. We got funded to try it out in 6 mental services, rural, remote, metro. I think what we need is the political will and the leadership. I again want to make this point. Just funding is change in funding is not enough. We need leadership, really leadership, good leadership, high quality leadership and commitment, and then we can bring various resources together and make it happen.
Okay, well, we'll move on to the next question. So I now want to ask you about innovation and innovations in practice. From your perspective, and Louise, I'm going to start with you on this one, just to give you forewarning. What innovative approaches do you think hold the most potential? And let's focus particularly in terms of preventing the suicide of people with BPD. Now, innovation in clinical treatment, might be the peer-led services, community-based services. What do you think really is out there that has the potential that we should build on?
That's a great question, and I'm sure I won't have all the answers at all. But I think we do need to innovate services, definitely. I think that one of the big problems is access, that people who would like to have access to services often don't feel they can. So we need to have many more options available of all different kinds that suit people where they're living, wherever that is, that, you know, more online kinds of options for people, more peer-led kind of lived experience run or driven options for people. I think briefer treatments that people can try out and see whether they're getting something valuable and then do more, so opting in for more, those kinds of more staged, I guess, approaches, so that we offer small tasters so that people can try things out and have some success and then come back and when they're ready for more. I think there's I'm not sure that I can think of other things just right on the spur of the moment, but I do think we're not good at innovating and trying things out. We often don't get support for doing that because we have to already show evidence that things work before you can get funding, and that's hard. It's hard to get funding for novel ideas. We've certainly tried some peer-led work you know, in a very small pilot, and that was very successful. So I think there are lots of ideas like that which are worth trying out and really thinking how we can fund them.
Rita, I was going to ask you anyway, but you're going to say, so I don't need to ask the question. Go right ahead.
I just wanted to add to Louise's with the stage levels of care. I think that needs to be both for increasing levels of care, but also to be supporting the person back into well-being with the option of being able to move to and fro depending on what life is throwing at them at the minute. So to me, so much of the current system is that you attend, say, an ED in a crisis presentation, you might be lucky to get a case manager, then you're discharged and basically told the only way you can get back into treatment is to go through ED. So by supporting people basically where they're at, I think that we will prevent a lot of escalations and a lot of ongoing distress.
And there's about 8 minutes.
Sorry, before you hand over.
10 minutes short.
But Rita,
So
I did
I'm doing
notice
a
in
screen
the
recording.
petition that you've put there,
Sorry,
you
I
talk
can't
about
help
the
that.
digital
Oh, I know you can't help
so
that.
is that
It's
an
exactly the
innovation
same
that
on
you
the
want
blog.
to see?
Oh, absolutely. So,
I don't want to
look,
do
we're
anything in
we're
the
aware
minutes.
that unfortunately
I'll show you
often
the
the
difference in
regular
the
helplines that
files.
people are told to contact don't necessarily work for people experiencing the distress of BPD. So, you know, the question we asked ourselves is what can we do differently? And the concept that we had was to develop a 24/7 digital type service.
there's
I call it a
an AO,
teleweb service,
an OAM
which is
and
phone
an
or
OAM.
web based, which is staffed by experienced clinicians that can actually tolerate and have the supervision to support a reasonably high level of distress without becoming reactive, supporting the person to give them some strategies to hopefully, that they feel that they can have ridden that emotional wave and it's abated somewhat, and can then in the morning to be able to refer them on to ongoing services. So to be acting sort of as a little bit of a staging post referral process, so that there's some more referrals, and there would also be contact with consumer and carer peers during the day. So the person has a couple of options of who they can speak to, and hopefully lead to envisage that this would lead to a higher level of integrated care. Now, there is actually a study from France that shows that this is highly effective, it's cost effective, and it really decreases the number of admissions to or presentations with suicidal attempts in ED.
Great, thanks, Rita. Brin.
Just on that question of innovation and what do we need to do differently, or what's an area that we can think about, my mind always turns to what people with lived experience say, and they often say to us, I wish I knew or somebody had explained this to me earlier. And I first started having these problems when I was at school, and I do think that there's a big piece for us to do. We're doing some of it, but I think we all need to do a lot more around working with schools, working with school counsellors, working with principals, and working with those that work with them, health and paediatricians and youth justice and a whole lot of others, to really be able to identify and understand these, when these things are showing up, and to detoxify them, to help the young person feel like they can be validated and they can be understood, and that they can start to feel like they can be held closer to our chests rather than pushed further away, and for them to lock themselves away as well. So I think that's the really big piece of work that would make a huge difference.
Great, thank you. And Sathya, I'm going to put you on the spot with another unscripted question. You talked about the need for more leadership. But we've got some leaders sitting here today, and great leaders. So what's the innovation in the leadership space? What do we need to do differently and new in that leadership space to take the agenda forward?
I'll give a slightly complicated answer, Peggy, if you don't mind. If you're focusing on suicide prevention, we know that by and large, people who die by suicide for this diagnosis seem to access public mental services. And almost all of them have gone through public mental services at one time or other. And when you look at that number compared to the community prevalence of 1%, it's really a small number. It's about 10% of the people who actually go to public mental health. Not all of them. And so those two facts. One is that only 10% of them go to public mental health. And most of the people who die by suicide go to public mental health before, unfortunately, they die by suicide. So if you could somehow offer treatments, generalist treatments, for that 10% of people, in principle, we should be able to at least try and prevent suicide. And that requires a mental health leadership. Number one, people in the mental systems to make, like we did for depression. Depression carried a lot of stigma before, and look at where we are now. At least in the Australian setting, depression is a highly treatable condition. Everybody knows what to do about depression. Even general practitioners know, psychologists know, psychiatrists know, everybody knows what to do. We need to reach that sort of a situation with borderline personality disorder, personality disorders, that everybody, even endocrinologists, even gynecologists, should be able to treat. everyone in the health profession should be able to do that. And if we could do that, yes, still there'll be challenges. Still there'll be some situations, some people who have much more complex needs, more higher societal behaviors, need extra support. And if you extrapolate that with Rita's model, that there are a group of people, I would say, lived experience people, family members, and clinicians being on call 24/7. It doesn't take too much of money. We worked out even the funding for that. And they can offer support if somebody comes to emergency department, or if the clinicians who are working with them in the emergency department not able to manage, help them out, offer that extra support. So there are models which we can work out, which doesn't cost too much of money. I'm convinced that what we need is more leadership and the will, the political will. And there is enough intellectual capital and experience. We've had two presidents of the International Society for Personality Disorders. One of them is sitting with us, and Andrew Chan was the other one. So we have enough expertise. What we are lacking is the leadership.
Okay. I'll move on to the next question, which is about integration of care, if I can. Sorry, Louise, did you want to add something? No. And Sathya, I was going to pose this question to you, so perhaps the microphone can go back to you. What do you believe are the most promising models for integrating care that could be applied across services to ensure that people with BPD receive timely, coordinated support, particularly when thoughts of suicide become overwhelming? And perhaps you've already kind of touched on that, but...
Again, but it's just expanding on what I was saying. It's really we need to start with the primary. We need to start with the person with the borderline personality disorder, as Brin points out, and that is a starting point. And second is the primary sector. We are not tapped into the resources of the primary sector adequately. Two of my colleagues are sitting here, Alison from PHN. We are trying to work out a model where could we support the GPs adequately, train them up, and not just one or two workshops, sustain training and support. And we know that in the Australian setting, we have almost everybody can access a general practitioner. So that if we could tap into the primary sector adequately, we might be able to make a big difference. Then also we are very siloed with the primary sector, the private sector, and the public sector. They're all siloed, and we're not really coordinating. Despite the Royal Commission recommendations we have had in Victoria, we haven't still started saying those changes. If we bring people together, we might be able to make that change.
Others? Louise, Cathy?
Yeah, I was going to talk a little bit about, I guess, thinking legislation coming in to talk about suicide prevention and actually making it everyone's responsibility. Fortunately, that happened in 2021 in South Australia, but really thinking about having a suicide prevention council and then having a statewide approach to suicide prevention. And at the moment, we are working with the Towards Zero Suicide framework and thinking about how do we have a bit of a universal response for everyone who presents with suicidal distress. And thinking, I guess I've been working with the regional local health networks, and so I think having the specialist services for personality disorder involved in setting these up is really fundamental in making sure from the outset we're incorporating personality disorders and presentations that people with BPD presenting in suicidal distress and having interventions that actually are addressing some of the concerns. And we have managed to have Gold Card, which obviously Project AIR established, agreed to be the treatment structure that anyone who presents in suicidal distress and is put on the suicide prevention pathway can have. So this is a brief intervention looking at what led to the crisis, providing some psychoeducation, and building a safety plan to help reduce the likelihood of going back into crisis, and then looking at referral on. And I think it fits beautifully with the Towards Zero framework, which is really thinking about how do we build capacity. I guess the other thing just to say, and I think it's really important, because often a lot of the clinicians we work with talk about the concern about working with risk and their concern about the coronial process and then that kind of defensive practice. And so looking at having or implementing a restorative, just and learning culture, I think, is fundamental to any suicide prevention pathway, and the success in terms of thinking about how do we move from this kind of blame culture, like what went wrong, who was responsible, to thinking about who was hurt and what do they need. And I think the more we can change the culture of our system to then support people feeling more confident to practice using evidence-based strategies, but I think fundamentally that will open up more compassion, which is, again, what the foundation for suicide prevention is.
Great, thanks, Cathy. The next question, and you've really, it's a lovely segue into the next question, which is actually what are the systemic and cultural barriers that within mental health services or the health system more broadly that you feel need to, most urgently need to change? And how can leaders like yourself actually start to drive that change? And now, who did I have picked out for that? You, Cathy.
Oh. Well, look, and I think it's been mentioned a lot today, and I think stigma. I think, I guess stigma is really compassion's nemesis, I think. And I think it is such a barrier to people being compassionate, to listening, to creating understanding. And I think training is a great way to try to reduce stigma. And I think what we found incredibly helpful is co-designing and co-delivering our training with people with lived experience. I think it's incredibly powerful, and all of the people who come to training that where a lived experience is co-delivering feedback how beneficial it is. We found attitudes have improved, empathy has improved, and people's treatment optimism for working with people with BPD have all improved with training. So how do we work with people with lived experience to develop their skills in using their lived experience for education purposes is key, because there's such wonderful resources, and in terms of how committed and dedicated they are to improving things in the system, I would really encourage you to think of how we do that. It's certainly, we've come up with some really structured ways to do that safely in acknowledgement of what it is asking of people is profound, but I think the benefits are really telling. So,
great. Others? Barriers?
I guess I've got a few ideas about barriers. One of the things that I wanted to have a think about is how slowly our systems change and how difficult it is for systems to actually be evidence-based and then to pivot and to improve what we do based on evidence. And so I'm thinking in one way about the new diagnostic systems, which have actually been out for more than 10 years already, and we're still talking about borderline personality disorder rather than a more generic idea of talking about personality disorder and the severity of someone's difficulties, which I think is a less stigmatizing way of talking about the challenges that people are experiencing. So, I'm aware we're sitting in a room that is very focused on borderline personality disorder, and I'm kind of talking about actually when we might need to change our language. So I think there's a whole lot of things like that actually we need to start changing the way we talk about personality disorder. We'll need to be thinking about all of our attention that sometimes goes on labelling, rather than thinking about what is the purpose of talking about a diagnosis. It's about trying to help people and ourselves think about what interventions might be helpful, what things we can do to respond to people with those difficulties. And I think sometimes the labelling issue is actually a barrier to us working things out better. We get caught up in that rather than thinking, how can we have our systems respond to the people that are experiencing these difficulties, whatever we want to call them. So I think there's a few things like that that I would probably say are challenges. Unfortunately, when people have interpersonal difficulties, clinicians find that sometimes challenging, and we need to support clinicians to be able to think, actually, this is appropriate, worthy work to be doing, rather than thinking it's uncomfortable and I'll shy away or avoid. So I think building confidence in clinicians and in their skills to be able to do the work with whoever comes through the door, rather than feeling like it's specialised work, which I've kind of mentioned already. And I think, we don't yet have a lot of good role models that can speak freely about having personality disorder and the challenges, so that it feels much more normalised, so that it feels like, yes, they are in our community, and we can see that they're thriving, or have been able to manage some of those challenges, or are challenged but are also, successfully winning at tennis championships, for example. So I think there's still, for us, many challenges to make it a normal part of mental health care. So they're the things that came to my mind first. Brin?
Yeah, so I mean, when we think about our hospitals and the way they were set up, if you look at the history of hospitals in Australia, they basically started from like military hospitals, post-war and so forth, and they're very much run along the same kind of lines of, they're disciplined institutions run by nurses with doctors, and they do a brilliant job with physical complaints and physical health, and they're really well set up, and that's what ED is all about, triage, about physical injury diagnosis, medical interventions and so forth. Is this the right touch for people with personality disorders? And the problem is that it's kind of like fitting people into the wrong place. It's like, this is not the door that you want to go through when you've got, struggling with your sense of self, your sense of safety, and your sense of relationships, and your sense of being in the world. So I think the innovation that we need is really to validate and build therapy teams and therapy as a medicine, which is based on relationships, which is a powerful medicine, but it's a different medicine than the one that we've kind of built. And I think that's where kind of we're stuck, is how do we validate that? Now, I know that I've been in a lot of different health services, and I know some of them are talking about building therapy teams and validating the fact that health practitioners actually do therapy, which is a nice thing. Because as soon as you do that, you then have to say, well, actually, we've got to look after our clinicians who are doing this work, and that helps with the whole issue around countertransference. So we're supporting the emotional work that involves. But that would be a major revolution, I think, for us to kind of like really take that on seriously.
Okay, Sathya?
I want to touch upon a slightly different topic of the culture of being risk averse. I think we need to ask ourselves, what have we really achieved by being risk averse, by doing all this checklist risk assessments, by using all punitive measures, hospitalizations, involuntary treatments in the last 50, 70 years? Have we really reduced suicide risk? We haven't. So it's time to really think about different models. Just reflecting on our experience, some of my colleagues from Spectrum are here. What we have learned in the last 26 years of Spectrum's existence is that we don't focus so much on the suicide risk. Of course, we are very concerned. We work with that, but we get on with the work of working with the person in front of us and doing the work. And as Brin very clearly pointed out, really starting point is the person, and that seems to reduce the risk. Not all the risk assessments that we do. I think when I talk to my colleagues quietly in the coffee rooms, what they tell, what will the coroner tell me? Who is going to come and defend me? I think the system, we need a leadership that needs to change that culture. We also engage with the colonial systems. they don't talk about this. They have a very different way of looking at this whole thing. For some reason, the clinical workforce is excessively preoccupied with what the coroner would say and where they would be exposed to litigations. I've been in this field now for nearly 20, 25 years. I can't think of any clinician who has been sued so far. And any number of coronial investigations which have actually blamed the clinician when it comes to borderline personality disorder. So I think there is a myth which is running around which we need to change.
And sorry, Sathya, just on that. So, do you think the clinicians fear? Because if it's not based in reality, where is it coming from? Is it coming from their administrators?
I think so. I think it's a leadership. Again, the systems perpetuate this sort of a myth. Also we have any number of systems way of looking at monitoring risk, and which actually some of it is really counterproductive. We need to really get down to the basics of what's the role of someone who is working in the mental system is to work with the person who is in front of you. Maybe it is medicines, maybe it is psychological work, maybe it is very fine psychotherapy, or just doing the good enough treatment. So I think we have lost our way, I think.
And I would just add to that, I don't think it's just in the mental health system. Again, it's across the health system, it's across other systems as well. And Cathy referred to the zero suicide approach, and one of the things that I think stood out to me when I first came to appreciate what they were aiming for was that sense of, from the leadership down, getting that message across that any interaction, doesn't matter who it's with, it's not just the clinicians that have to make the difference. Anyone can make a difference, positive or negative, and it behoves us to understand that every interaction is a touch point where we can make, a change to the trajectory. Okay, yeah, Louise, go ahead.
No, you said. I guess I was just going to add that it's understandable that people are defensive, because actually clinicians really want to help people, and they are genuinely worried that this person they're working with is talking about harming themselves, talking about wanting to die. That's a really terrifying thing to listen to. I'm sure all the family members feel terrified when they hear those things. So I think it makes sense that people become defensive. I think that the part of the message that doesn't always get through is that the way to change someone who's feeling suicidal, not change them, but to help them manage that, is to have their life become better. Because if you want to live your life, you don't need to die. We don't need to die now. And so I think clinicians feel worried, but they're not always sure what to do about that. And going back to what we were talking before about general skills, good clinical care can help you work with people to help their lives get better. We need to think more broadly than just their personality disorder symptoms, because that's not always what the person wants to change most. It's not the thing that's going to make their life better, having less of these symptoms. Sometimes it's about having ordinary things, having meaningful activities, having a job, having educational pathways, having better relationships, enjoying life, living in housing that actually feels comfortable, having a place to rent rather than having no place to rent. All of those things make life meaningful, and then we don't want to die. So I think it's about really helping clinicians feel more confident that they have the skills to be able to help people have better lives, and be confident that their service isn't going to come down on them if they work on those things, which is what Sathya was saying. So I think there's a number of things we can do to make care seem more something that we can all provide with our skills.
And I'd just like to add to that I think lived experience really has got a tremendous role that can play in that. So potentially not everybody needs to see a clinician. Sometimes just engagement and with a peer who gets it, has experienced the same thing, just helps the person to feel validated and understood, and that I'm not alone. On a separate point, don't think I'm digressing, but I think there's also an important point that, to me, corporate identity seems to matter more for some organisations than actually the people that we're supposedly here to support. Now, I know it's a challenge. Corporate identity is necessary for funding, for prestige, all sorts of things, but please, let's not lose sight of the fact that we're really wanting to support a person in distress.
Thanks, Rita. You can keep the microphone because I'm going to direct the next question to you. And it really is, I guess, putting the challenge out there. Is there actually a collective vision to make 1 in 10 history? And if you think there is, how can all of the specialist services, the BPD Foundation, and others who are here in the room today, the PHNs, lived experience, community groups, etc., how can they all work better together to reduce the risk of suicide?
Well, okay. So part of the questions I thought that you originally were going to be asking is zero suicide achievable? And whilst I would love to see it achievable, it's got to be a balance between promoting a person's autonomy but also supporting them to be getting the treatment and that they need, treatment and support they need when they need it. So it's a balance, and yes, I would love to see zero suicides from BPD. And I think it can be a reality if people can access what they need early on when they first become unwell, or even before they become unwell, in the schools when they're feeling that they're not belonging, that they're being bullied, all these sorts of things, that they're given some strategies to be helping. So moving on to your other question, I really feel that in the organisations that are currently in Australia, and we've got 4 here, and Megan spoke before, PHN, that there is actually a greater congruence of interests than differences. And it's a process, I think, of trying to work through some of those differences and really working in a space where we can be collaborative and to be listening to and learning from one another, and to be combining our resources and our energies, because rather than being separate silos working in isolation, we could be much stronger together.
So it's Mother Rita now, not Mother Teresa. Others? Is there the collective vision? And what do we need to do to work better together?
I think so. The fact that all of us are sitting here and talking about it, and we are the organizations, the larger organizations in the country in this field, we all seem to be having very similar views about how to go about. And thanks to Rita and others in the BPD Foundation who are trying to bring us together. We need a glue. We need a glue to bring all of us together and stick together and collaborate more. I think that is, I keep going back to, in my mind, that requires leadership. We can't really be expecting the lived experience workforce to carry that huge burden of leadership, and they are doing a fantastic job, but it's morally doesn't sit very well with me that we expect them to do. I know how much of pro bono work Rita does and others too, and I have a couple of clinicians, a couple of lived experience staff, 0.2 and 0.4 EFT, but the amount of work they do is enormous. I think we need to, coming back to leadership for me.
Others? Cathy?
Well, Peggy, you were saying around it being a social justice issue and really thinking that this is cross-department and not just health. And I think that's one of the things, yes, I think we are united and we are all have consistent messages that we are promoting, which is wonderful. And I think that says a lot. But I think, how do we engage with other departments to bring them along, because it's their responsibility as well. So I think strategically together, I guess it's about identifying where are those key opportunities that we can intersect and influence and bring other departments along and other sectors in the community in addition to health or mental health.
Brin, did you want to add anything?
Yeah, like I said, I don't think it's rocket science what we need to do, and I think we're all on the same page. And the messages that we've heard this morning have been so powerful and so validating and so true in so many different ways around what is the problem we're trying to work with here and what's the way to solve it. So it really comes down to how do we as a nation do it better than how we are at the moment, which is often patchy and fragmentary, and does, like, there's this big kind of like vortex of invisibility for personality disorders, and we've got to start there, I think.
So are there any lessons from our international colleagues in terms of how you build that glue?
I wish there were. I think I liked your idea of going to a different diagnoses and actually looking at the way that they've done it. I think there's a lot of jealousy in the personality disorders area when they look at other disorders and how well they have done. Like you think like cancer is a great example of a highly stigmatized disease in the 60s and the 50s to now being like a badge of honor, really, and making it mainstream. And I think that kind of like transformation of the narrative is really what we'd like to see in our area.
Okay, I'm conscious we've got about 5 minutes left, and I did have some other questions, but I'm just going to go to our last one, which is your one wish. If I was here with my magic wand, I don't actually have one, by the way, but if I did, and I was able to grant you one wish that could change the life trajectory for people with BPD and their families, what would that one wish be? And Rita, you've got the microphone, so let's start with you.
My one wish, okay, that I no longer hear people being told that they can't get treatment and support because of 3 letters. And as Lois Choi Kane, one of the eminent people from the States, says, is it worse to tell someone they've got a condition that you can't treat, or a condition that can be treated but you can't access treatment?
And I would just echo that by saying I would wish that personality disorder was treated like all the other mental illnesses and part of routine care, so that you were not excluded because of that.
No, my one wish is that there'll be no suicide for borderline personality disorder, because I believe it is preventable. And one of our colleagues, Cathy is here from the Safe Care Victoria, who promote Zero Suicide Initiative. So that's my wish.
I'm going to go a little bit bigger and think some of our presenters earlier in the day spoke about this. But I think when we're thinking suicide prevention, one of the components is also not only reducing the distress that people experience and reducing deaths by suicide, but also reducing stress that causes or leads to feeling suicidal. And so I would go around eliminating violence again, and gender-based violence. So if we can eliminate violence against women and children, I think not only will it reduce distress and that leads to people feeling suicidal, but also it will enhance our community's capacity to respond when people are in suicidal distress.
And Brin?
I hope we all get to keep all of our wishes.
It's such a big question. I can't help but think about prevention and early intervention, and I do think that there are people who did get the help that they needed early, and had a totally different trajectory than those that didn't. And I also just wanted to mention that when you talk about early intervention, you kind of have to talk about parenting as well. And you have to be thinking about not only the young person, but also their family. And that, I think, raises a whole lot of other issues that I think that are very important. And we had a lovely presentation on how to support carers today. And so I think it's not just about the person who's struggling, but I think it's about the relationships and the people around them and the family that we need to be holding close to our hearts.
Great. So if I can just do a quick recap to wind us up. I mean, what we've heard today is the need for a whole range of things. We need to have, we need to tackle stigma and increase understanding. We need to look at early detection and diagnosis and early intervention, not just for the individuals themselves, but for those around them. And that brings in other systems, you know, family and community services, housing, etc. We need clinical services that are across the spectrum of care, not just in specialised mental health. We need models that allow it, services to actually be accessible from wherever you are, and that includes potentially digital services. We need more leadership. We need that glue to actually try and put all of this together. And I'm sure there's other things that we've covered that I haven't recalled in the heat of the moment. Just to wrap up, I mean, thank you all so much. That's been, I think, a highly informative discussion. Is there any one thing that we haven't mentioned in terms of what's needed that you would just like your last couple of words to actually highlight? Rita, you've got the microphone again.
I think for government to make this a priority, put this on the priority agenda and really take it seriously, and to commit to ongoing funding for projects. There's some brilliant projects that start up and after 12 months, 2 years, they run out of funding and that resource is lost often.
Okay. Louise?
Oh, I'm shaking my head. Yeah, absolutely. I think when I was talking about there are not so many role models who are willing to stand out, I think that is one of the key things that makes a difference, that gets the voice up in Parliament to take notice, that actually we need people to be able to stand up and say, this is something I'm struggling with and there are many people out there also struggling. I kind of wonder if it will take that for the voices to really get heard in Parliament. It's not that we haven't been there and knocked on the door and had consensus statements and things like that. It's that it's not then being acted on and made a priority and taken, you know, into the routine, accepted as routine. I think if we focus very, very narrowly on borderline personality disorder, that risks us then not being seen as generalist and a general thing that needs to be a kind of part of everybody's business. So I'm a bit worried about that focus being too narrow. Otherwise, I'm not sure where else we go.
Thank you. Sathya?
For me, it is moving away from highly specialized psychotherapies to good clinical care, good enough treatments. Keep the highly specialized care for a few, but and look at jobs and housing. And of course, that's a big social problem, and those are very strong determinants.
One of the things that we've been grappling with is when we have people with really high levels of complexity, often they are receiving paid caring support. Often, however, those carers, whether it's in institutions or in the community, often have the lowest level of training and perhaps no mental health training. So when we think in the prisons, custodial officers, in DCP Resi Care, we have the youth workers in that space. and these workers are struggling with supporting the most complex consumers, and to think, how do we provide them with training and upskill them to be able to support people within their scope of their role. So thinking like the kind of family connections kinds of skills, or I guess we've been looking at like the GPM, the family guidelines in that. How do we kind of use those principles to help people provide care for people who are incredibly complex and at high risk of suicide?
Great. And Brin, our international president, the last word from you. Thank you.
You can wrap up.
Look, there's, I guess my main focus was really about just about how important it is for us to get the message that there's no escape here. Like these are already our clients. These are people in the community. These are our neighbours. These are our friends, and that we can't somehow make the problem go away. So we absolutely have to do something better than what we're doing.
Great. Can I thank you all for your contribution today? It's been a fantastic discussion, and can you join me in thanking the panel?